Welcome. Let me just get my slides up. I'm going to talk about developmental or complex trauma in adolescence, particularly with multiple and intersecting vulnerabilities who present often with risk and kind of low or non-conventional help seeking. I've called this talk Fallout, and I'll kind of explain that in a moment why. So just to present an anonymized, it's an amalgam of a number of real cases, but fully anonymized case. We're going to call her Jay, a female, 18 years old, who's been in multiple placements from the age of 6. Her social worker now fears that she's using crack and heroin and is at risk of both criminal and sexual exploitation in order for her to pay for this. And almost as an afterthought in the referral, that she's thought to be probably alcohol dependent as well. She's currently temporarily living with her grandmother as following another kind of incident at the last in a long line of supported hostels and fostering arrangements. She's been removed from that place on account of disturbances on site, let's call it that. Her family history is, as one might even now imagine, it's troubled. Father suffers from chronic psychosis, has had multiple hospitalizations and multiple incarcerations in prison. There's been no contact with him for 5 years. Her mother has a chronic relapsing and remitting relationship with heroin and crack, and intermittently gets engaged in sex work, presumably to pay for the drugs when she's in a active using phase. And there's a past history in her own story of emotional abuse and neglect. The grandmother, or mother of that mother, has a diagnosis of bipolar disorder, is currently in a stable phase, but is expressing to the social worker that she's really unable to manage Jay in her small house. Jay's using her house already as a place to host parties for friends, as she describes them, who are mainly quite older and street homeless. Jay explains to us in our first meeting that street homeless are people that she feels closest to, that she feels these are the people that most understand her, rather than some of her old acquaintances. And Jay expresses a kind of chronic despair about her future and her capacity to make any meaningful changes in what she sees as something that is happening to her rather than her making particularly active choices. There's no overt self-injurious behavior that she has in the past cut herself for brief periods, but she is drinking all day with active and potentially quite sort of worrying withdrawal reactions when she's deprived of alcohol that do suggest that she's going to need a medically assisted detox, which is rare at that age. It takes a few years to build that kind of physiological dependency on alcohol. It turns out, on the other hand, that the reports of her using crack and heroin have been slightly overstated. There's been a few exploratory tries of these drugs, but she's not regularly using them and is, if you like, more than aware from the model of her own mother that that's something that she doesn't want to get involved in heavily. When we kind of come to invite her to think a little bit about her past, she's absolutely clear, I've got enough to deal with in the here and now. And so here is Jay, and we'll just hold her in our minds and we'll come back to her towards the end of my talk if we could, as a young person who somewhat typifies, maybe at the more extreme ends, the kinds of young people that the team I work with in the NHS look after adolescents with substance use problems as their headline, but normally this is just a flag for multiple intersecting other vulnerabilities. I called this talk Fallout, and I suppose I was kind of thinking in terms of trauma leading to sort of, if you like, to some extent, some recognizable after effects. And I was sort of thinking about the similarity between that and a nuclear accident, and that sense that there are sort of predictable outcomes, but also the fact that, you know, these outcomes play out in a field which is massively complex, the weather systems being just one of them, so that it's very hard to predict exactly how things will flush out. And having thought this was an interesting kind of parallel, I then kind of checked out this map, and it found that the map that I showed, the Fallout map, is entirely fake. It's not a real map at all. Now, we don't know the intentions of the person that made that map. Maybe they were simply mischievous, maybe they were well-intentioned, but it went around on the internet, and everybody got very excited for quite unhelpful reasons. There wasn't a nuclear cloud and a fallout cloud in the way that you might if you'd had a different kind of nuclear disaster. I suppose that's where we want to start, that trauma is not a diagnosis any more than a nuclear event is fallout. Trauma informed is a phrase that gets used a lot, and I don't hear anybody banging the drum for trauma uninformed or trauma ill-informed work. And I'm going to be sort of arguing, or kind of helping us kind of state the obvious, really, that being trauma informed is necessary but is insufficient as a treatment modality on its own. Very important that we are properly informed about trauma, but that you know, just being trauma informed doesn't necessarily make the difference. In order to think about that, I'm going to spend just a few moments with my psychiatric hat on, just kind of, if you like, reviewing the different ways diagnostic boundaries are formed to define the kind of cluster of symptoms, and particularly think about PTSD and the new diagnosis of complex PTSD that ICD-11 talks about. But I then want to kind of really expand out and to think about how complex PTSD, which I do think is a helpful labeling of a particular cluster of the kind of fallout that happens, how it requires a networked approach that also requires continued attention to the sort of dynamics of the dyadic relationships that form those kinds of networks. So let me press on, if I may, to think about, you know, defining what do we mean by the kind of fallout, the symptom clusters that happen. DSM-5, Diagnostical Statistical Manual, has, of course, a requirement that there is exposure to the kinds of trauma incidents that David earlier talked about. There are intrusion symptoms, what might in the past have been described as flashbacks, but there are multiple listed. There are persistent avoidance symptoms, and again, multiple versions and forms of avoidance that might be formed are listed. And there are alterations in the person's arousal and reactivity following exposure to the trauma. And again, multiple versions and forms that those can be listed in. And an additional feature, there are negative alterations in cognitions and mood. And again, lots of different ways in which that might express itself. And these symptoms have to be present for at least a month before you can make a diagnosis, and must be accompanied by distress and or impairment. Very important. That subjective experience of the patient is taken into account. Now, it's kind of rather an interesting, and it's a very good paper, just kind of, if you like, reviewing this diagnostic categories. Cloyter in the British Journal of Psychiatry, I don't know whether they did the sums themselves, but worked out that there are 636,120 possible combinations of the different symptoms that could all, in their different ways, lead to a diagnosis of PTSD. And this is, if you like, the dilemma of diagnostic manuals in a nutshell. Do we create a very tight diagnosis in which the subjects who fall under that kind of categorization of clustering are pretty similar to each other, or do we have a much looser, larger box within which, where individuals at different ends of that that kind of defined diagnostic category might actually be individually very different from each other. The alternative, or not only one of many, there are many other diagnostic frameworks, but these are the two most well-used ones, is ICD, the International Classification of Diseases, which has just released its 11th variation. And DSM, I think ICD takes a rather kind of tighter definition of PTSD, but adds this extra category called complex PTSD, which has a more of a developmental multiple approach to it. So PTSD is very similar to the old definitions where you'd have flashbacks, avoidance, and hypervigilance, exposure, re-experiencing avoidance, and current threat. And then complex PTSD is an addition to a diagnosis of PTSD. So in addition, you'd see disturbances in self-organization, in emotion regulation, and negative self-concept, and persistent difficulties in relationships. At this point, I think it's entirely legitimate to say, well, what's the difference between complex PTSD and PTSD with co-occurring borderline personality disorder? That's a diagnostic framing that is one that I don't use the language in my clinical practice, but I think we must be respectful of the research that's gone into the way that different symptoms of suffering and distress and impairment can cluster. So not a name that I feel comfortable using, but just let's bear with to think about these ways of expressing difference. So individuals with complex PTSD, they have self-image difficulties that are severe but stable. They have a fairly fixed negative self-complex, and I think that concept, and I think that that would fit with the picture of Jay that I pointed out. Rather different from the classic self-image difficulties where the descriptions of BPD would go, where there's this kind of swinging backwards and forwards between rather highly positive self-perceptions and into very negative ones. And it's that vacillation, the instability of self-image that is more apparent. In complex PTSD, there is a tendency to avoid and have difficulty maintaining relationships, more during periods of conflict or high emotion, but that's the kind of consistency. There's an avoidance of relationships, kind of full stop. Whereas the borderline personality disorder definitions talk about much more of a kind of coming and going, these idealization and denigration. So there's again this sort of vacillating or kind of instability rather than a kind of stable avoidance in that. The complex PTSD doesn't involve suicidality or self-injury, whereas that's pretty core to the features of the borderline personality disorder as they're described, and are often a first target of treatment. So I suppose we kind of recognize that in both of these situations where people are in distress, are suffering, they've got impairment, they may encounter a phrase which is that they're not ready for therapy, which I'm going to suggest means that my approach or methods or techniques are perhaps not what's required or helpful at this point. It might be that it's the therapy that's on offer that is not ready for them. Two important statements that are going to kind of color the second half of this talk. So first of all, trauma suffered in isolation is what most predicts the development of symptoms. That's a statement that Peter Fonagy has made on a number of occasions, and I found that a very helpful framing for this. And then this conceptual idea of, if you like, the pathway into post-trauma psychopathology from Eamon McCrory and colleagues at UCL, the notion of social thinning, something that happens over time that is, if you like, the kind of one of the pathways to psychopathologies. And I'm going to be arguing that mentalizing is perhaps best thought of as, in addition to what we already understand about it, perhaps more so, that it's a function of social capital, that it's a function of connectedness or its lack in a life. Very briefly, I refer people to this notion of what we call we mode thinking. It's a great book by Finnish philosopher and I think he's a developmental psychologist as well as a philosopher, but a philosopher, certainly, Raimo Tuomela, the philosophy of sociality. This idea that as humans, when we have a shared intentional task that we are working together with, that kind of state of mind where we are doing this is how we operate, we are trying to achieve, creates, if you like, more of a sense of access to information about the behavior of our partners and our colleagues than one might expect without that state of mind, the we mode of thinking. This is a version of interactionism, which kind of, if you like, invites us to step aside from solely the internal operations of the brain and to see that there are modes of thinking that are, by their very definition, interactional, that as interacting agents, we have their minds sort of shared in the doing rather than simply the thinking. So I'll come back to we mode thinking. Well, in fact, here we are. So here's a young mother. Let's imagine this is perhaps Jay in a different set of circumstances, who's thinking her baby into a mental existence, both in the womb and certainly after the birth. It's the extent to which the mother can reflect the baby's mental state in her expressions, in her verbalizations, and the baby sees that in the mother's mind. The baby then receives back, if you like, reflections, mentalizings and begins to develop a sense of self, a sense of agency, and to develop the capacity themselves to mentalize. But the capacity for the mother to do this in that extraordinary reciprocal dyadic relationship is massively dependent on her access to perhaps a supportive partner, perhaps a health visitor, perhaps a friendly neighbor who could mentalize her as well, and that they may have some shared intentions, a we mode as a group of people around this young mother. Let's keep the baby safe and let's keep the mother safe. And they may have some shared assumptions around that. This is hard to do this, but it is possible that there is some valid knowledge and some real skills that exist, and that, you know, as responsible people in this we mode of existence where we are trying to help this mother with her young infant, we're going to follow the rules, if you like, the safety rules. And the extent to which we are held in the minds of others around us, maybe perhaps our professional colleagues, perhaps each other, perhaps our family and friends' minds, will be directly kind of relevant to the extent to which we're able to hold in mind the mind of this very distressed and devastated and perhaps lonely young mother. And trust, therefore, is one of the key problems, particularly for those people who are trying to help work with people with complex PTSD. I meet a young person and it can feel as though there's a door very closely shut between what's in my mind, which I may feel and have some reason to believe is meaningful help, and them. And that what kind of enables the opening of that door is to evoke, in some sense, a state of feeling understood in the young person I'm working with. Can they look at me and in my face, in my voice, have a sense that I have kind of beheld them in a way that's compassionate and makes sense, feels like it is them. If I can do that, rare in those moments that it is, it does two things. Number one, it will draw the attention of that young person to my mind. And the other thing that it will do is to begin to develop in that moment some trust in the relevance of what's in my mind to what might work and be effective and be helpful in their life, in the context of their world, their social world. And that's the process that we talk about as epistemic trust, a trust that is, if you like, by kind of nature, there's a sort of gated channel to opening that door. And the key, or one of the kind of most profound keys, seems to be the capacity for one person to accurately mentalize the other, which opens this door to taking in and being able to absorb learning. I'm not going to spend very much time talking about this, but David briefly mentioned the P factor, this kind of common factor. And I suppose the question about the P factor is, well, what is it? And I think it's a very helpful kind of model, that one way of making sense of this general psychopathology factor might well be social thinning, this kind of broken use of epistemic trust, the inability to use the help that is available to one. That might give us a better idea as to why it is that evidence-based practices work really well for about 70% of the population, but not really very well for about 30%, who tend to be those people who have high P factors, low epistemic trust. They're just closed. They have that avoidance that we've talked about. So here is J, and this is what we'd call a program, a professional sort of epistemigram, you could call it. I don't mind what you call it. It's just a way of trying to align the relationships. And you can see that J is connected to a rather sort of kind of tightly clumped, non-differentiated group of people that she does refer to as friends, and yet by her own admission she says we don't really care about each other, we just like getting off our heads together. She has a relatively good relationship with her grandmother, a poor relationship with her mother. She's really fallen out with the housing officer who's kind of evicted her from her latest hostel. She's got a reasonable relationship with a social worker, and she meets her key worker from my team, who has already some relationships to these rather more remote adult substance use service, who, given her age, would probably be managing a medical detox, and a link to the Access GP practice, who particularly specialize with homelessness. And over time, that network, if you like, morphs a bit. And I suppose one of the approaches in our work is not just to think about the dyadic relationships. How do I thicken that line between J and me, to kind of, if you like, build the epistemic trust. But how do I also think about the relationships that I have with the other minds that are arrayed around Jay? So how do I meet her multiple needs? And you can see that this access homelessness GP practice has gone from really no relationship to really an important relationship, if anything, closer than our key workers relationship, which is probably just as we want it to be, because they are a brilliant service and are likely to be with them longer than my team, which is technically a child and adolescent service. So Jay is moving out from our AMBIT, our sphere of influence. And we've also started to introduce through that homelessness service, the adult substance use service. And a little bit of drawing in of the housing work. And you can see again, a kind of, there's a little bit more differentiation between this friendship group. Jay can see that some of them are different from others. They're not all the same. And there's a certain amount of perhaps a little bit more distancing, which we might feel is positive. That might be rather mother's apple pie and all that. But that, I think, gives an idea of the kind of shift in emphasis that this approach AMBIT has developed to be helpful with these very complex clients, adaptive mentalization based integrative treatment. Mentalizing is the sort of the core of this approach that carries the weight, but we want to, if you like, focus on those dyadic relationships to help support workers who are not highly trained, they're not psychoanalytically trained, but to use some of the dynamics of what mentalizing practice might look like, to help them sort of find the balance between scaffolding their own relationship and scaffolding and supporting to build the relationships between Jay, say, and the other key workers in her network. And at the same time, managing the risk. Managing risk is an interventional stance often that involves power and the infliction, whereas scaffolding relationships can feel much more cozy and cuddly. And in our work, we're constantly balancing. So AMBIT says that holding of a balance is by definition anxiety provoking. And that means that my mentalizing as the worker is constantly at threat because I'm trying to find the right place to stand. And likewise, therefore, while we build individual key relationships, we also need to attend to the team. Is my team holding me in mind? And on the network front, we're constantly trying to look at the multiple needs that Jay, for instance, presents us with, a different crisis every week, and to, if you like, in a contingent way, try to meet those needs, not necessarily always through us, but through connections. But at the same time, not allowing that network of people to become more and more what we would call disintegrated, but to try to do our bit to build relationships across networks, to be as mentalizing of the members of that network as we can be of, or could be, towards Jay. And then finally, to have a team that has an active sort of commitment to holding that balance between respect for evidence-based practice, where it can be applied and is applied, but also a respect for that sort of street knowledge, the local practice and expertise, knowing who's who in the network around Jay in this particular locality, as well as knowing something perhaps of the culture and the kind of context that no evidence-based practice can necessarily speak to. And finding the right balance, again, is something that teams must hold to. So in the end, what we're after is complex developmental trauma being understood as something that's, you know, a highly pervasive and more pervasive than simple PTSD, that its etiology is much more than just fallout from an event, but is systemically and sometimes systematically, in terms of poverty and exclusion, maintained, that we can't lose that in our effort to make meaningful connections with a very vulnerable person. Complex PTSD calls for multimodal approaches that can build individual experiences of contingency in the care. Jay is not somebody who waits. She needs to know that something will be met quickly. And at the same time, we need to be able to hold a kind of therapeutic kind of compass up, so that we'll be working both intrapsychically in a relational, systemic form, and an organizational and a network setting, across the sort of social economics of her dilemma, and often in the legal and political one, and biologically. And that, you know, to fail to address this really would amount to a kind of gaslighting of Jay, as if the difficulties that she has and the failure of our help to be helpful is our fault. On the other hand, when we've managed to engage her, what AMBIT is about is trying to create the frame that might then enable and support precisely the kind of evidence-based practice, such as trauma-focused CBT or other evidence-based interventions for trauma that might then help shift Jay further along. Thanks very much for listening.